much for coming and joining me tonight to talk about this important issue. I want to first give thanks to the League of Women Voters. I think that it's very gratifying as an organizer to have an organization immediately come to your mission and say, I'm fully supportive. But I appreciate even more when an organization puts in the thoughtful work that it takes to come to the right conclusion. And the League of Women Voters held seminars and debates and forums across the state before deciding to take a position on this issue. And for that, I am eternally grateful. So I'm a big fan of the League of Women Voters. My organization, Compassionate Choices, is a national nonprofit organization, and we work to improve care, expand options, and empower everyone to chart their own end-of-life journey. That's our mission, and we engage in a number of activities beyond just legislative advocacy. We do community education to talk to people about the importance of advanced care planning. We developed a tool for how people can plan for the care that they want should they get a dementia or Alzheimer's diagnosis, so how all of us can control what happens to us at the end of our lives in the event of one of those devastating diagnoses. We help to improve access and education around hospice and palliative care. And we have a free, toll-free end-of-life consultation project. So families, people who have serious illnesses can call our organization and get help navigating the care that they want at the end of their lives, no matter what state they live in. We also support healthcare professionals by engaging in peer-to-peer education and continuing medical education programs for providers across the country. We do legal advocacy, representing families of loved ones whose wishes were not honored at the end of their lives. And of course, we do policy advocacy, which is part of the legislative work that I do to expand the options across the country. Tonight, we're going to cover a number of topics. First, we'll talk about what care options are available for people in New York right now, people who are terminally ill. We'll talk about medical aid in dying, what it is and where it's authorized currently. I will tell you about the bill pending in the New York State Legislature, New York's Medical Aid in Dying Act. And we'll talk about the legislative process. Where do things stand now and what needs to happen to make this compassionate option a reality in New York? We'll talk about the benefits of a medical aid in dying law and how we're going to get to the finish line in 2025 and what you all can do to help us get there. And of course, I'll stop periodically and ask for questions. So, by way of introduction, I actually like to start with one of my personal heroes, Dr. Atul Gawande, who is a surgeon and an author. Some of you who are in book groups may have read this book. It's called Being Mortal. It's one of the best books I've ever read. He is engaging, he tells stories, he's just such an accessible author, and he worked for the Biden administration for a while. Over the past few years. And one of the things he says, and I like to start out the presentation this way, is he says, life is meaningful because it's a story. And in stories, endings matter. And when we think about the end of our lives, which some of us do more often than others, you might imagine that you'd like your life to end, maybe lying on a clean bed with a warm breeze blowing through a window and the curtains blowing and surrounded by grandchildren telling you how much they loved you and how much you meant to them. But it doesn't often happen that way, and it's quite rare, actually. And that's because of how we die in this country and where we die, mostly. These are the latest statistics from the Centers for Disease Control from 2022, and it shows that most people are dying of heart disease and cancer, and then unintentional injuries. But these are the kinds of illnesses, and the diseases vary, and the death profile, as it's now called, looks very different for different kinds of cancers, but oftentimes people are not able to have that kind of a peaceful end with these diseases. And it matters where you die also. The majority of Americans say that they want to die in their own homes. Some people don't. They don't want to leave their loved ones with that memory. They'd rather be somewhere else. And for many, many centuries, people were dying at home, surrounded by their loved ones. And then medical care became much more available at the end of life, and people were dying in the hospital. But you'll see the statistics from 2000 show that the number of people dying in hospitals is starting to decline. And that's in part due to the excellent hospice care that's now being offered that allows people to die peacefully at home. So that number is decreasing, but it's certainly not near where we need it to be to realize what most people want for the end of their lives. You'll see that deaths in a decedent's home is increasing, and that number will soon, I think, converge, and we'll see more people dying at home the way that they want. Certainly medical aid in dying is one policy that allows for that to happen more easily. It's really important to note that about 2/3 of American adults have not completed an advance directive. And I'm definitely not going to embarrass all of you and ask you to raise your hands, but if we were doing a workshop on advance directives, I would do that. More important, though, than just doing your advance directives is having the conversations with people around you about what you want at the end of your life. But as a result of people not memorializing what kind of care they want at the end of their lives, the treatment that most Americans would choose near the end of their lives are often very different from the treatments that they receive. That means that people are receiving far more aggressive treatment at the end, which may not only shorten their life, paradoxically, but also definitely impedes the quality of their life. And that is often not what people want. Some people want everything until the very end, and that is their right, limited only by your ability to pay for that. But a lot of people would rather choose the quality and maybe a little bit longer, even if they know that death is certain, which it is for all of us, by the way. Reminded of that by Senator Joni Ernst the other day. I don't know if anyone saw that, but I'm still trying to wrap my mind around that. It is often said that we are all equal in death and taxes, but neither of those things is true, right? And certainly not in taxes, but definitely not in death either. And that is because people receive far different treatment at the end of life for a whole host of reasons, but they're also planning for the end of their lives differently. 35% of white people have put their advance directives in a written form, but only 15% of African Americans have, and only 11% of Hispanics and Latinos. And I've seen some statistics that show that far fewer Asian American people put their wishes in writing. And so what does this mean? That means that people are less likely to receive palliative care, they're less likely to receive end-of-life planning services, less likely to receive hospice care because they may not understand what it is, and they're more likely to receive aggressive end-of-life care. In part, that's because of our very warped billing system. It's profitable to give people more care than they might actually want at the end of their lives. And there are a number of factors leading to these disparities. There's discordance between providers and patients in terms of race, inaccessible socioeconomic resources, geography, bias, discrimination, and lack of cultural competency. So all of these factors lead to the discrepancies in end-of-life care. So let's talk about what those care options are for people at the end of their lives. When you are terminally ill, you have the right to avail yourself of all available medical treatments and interventions, limited only by your ability to pay, which is no small limitation. You also have the right to discontinue or refuse any medical treatments, and that's been a right upheld by the United States Supreme Court for any decisionally capable adult. You have the right to receive palliative care, including hospice services, and we'll talk about what that is in a moment. You can voluntarily stop eating and drinking. That's, again, a right of decisionally capable adults. And if none of those options is appealing or provides relief, you also have the ability to seek what's called palliative sedation, and we'll talk about what that is in a moment as well. In now 12 jurisdictions in the United States, you do have access to medical aid in dying, but not yet here in New York. So, and I'll define what medical aid in dying is in a moment. But what is palliative care? Palliative care is for people at any age, at any stage of their illness, whether that illness is curable, chronic, or life-threatening. So palliative care is available to young people, to people undergoing a serious illness who may not be terminally ill. What it does is it focuses on improving a patient's quality of life by managing pain and other distressing symptoms of a serious illness. And palliative care is often provided along with other medical treatments. Hospice is a form of palliative care, but it's for patients in their last year of life here in New York. In many states, you're only eligible for hospice when you have a prognosis of 6 months or less. And that, again, it was a billing decision by the federal government. But New York is a little bit more enlightened than that, and so we allow people with a year prognosis to access hospice services. And hospice is not a place. It is a set of services that can be provided wherever a patient calls home, whether that is a physical hospice center, a hospital, a long-term care facility, or wherever the patient resides. And it's provided by a team of healthcare professionals, including physicians, nurses, social workers, pharmacists, chaplains, and others who listen to the patient's goals of care and align their treatments with what is important to them. They address more than just physical needs. They also provide emotional, spiritual, and practical support. And these services from hospice are available not just to the patient, but to the patient's family as well. Voluntarily stopping eating and drinking is a conscious decision to refuse food and fluids of any kind, including artificial nutrition and or hydration. This option can be chosen by any decisionally capable adult who has the physical ability to eat and drink, but consciously refuses foods and fluid in order to advance the time of their death. A determined and well-informed individual with significant caregiving and hospice support can successfully choose this end-of-life option, but it is not easy. We have many supporters who have come to us after experiencing the death of a loved one who stopped eating and drinking, who said it was just torture to watch their loved one waste away like that. There's a lot of research that shows what happens to the body, and pain and discomfort diminish after a certain period of time that you've stopped, and then the death can be quite peaceful. For others, it involves a lot of agitation, and it's very difficult for the family to watch. The United States Supreme Court has affirmed the right of mentally capable individuals to refuse all medical therapies, as I said before, and this includes food and fluids. So people who express this desire can't be force hydrated or force fed. So if those options are not providing enough relief, and the person is still suffering at the end of their lives, they can undergo something that's called palliative sedation. And it's known by a number of different terminologies in the medical vocabulary. It's known as terminal sedation, continuous deep sedation, or sedation for intractable distress of a dying patient. That's a mouthful. So another way to think about it is being placed in a medical coma while nutrition and hydration are withheld. It's the use of medications to induce a decreased or absent awareness in order to relieve otherwise intractable suffering at the end of life. Some patients who are undergoing aggressive symptom control measures still have severe suffering from the underlying disease or even from the therapy-related adverse effects. And so this is an option for some of those people. The problem with palliative sedation is sometimes it's more of an art than it is a science. If you give the person too much of this medication, you cause them to die. If you give them too little, they'll wake up in the midst of this. And that has happened to people who are undergoing palliative sedation. And imagine how disorienting it would be. And then the care team, the family is running around the person trying to recalibrate the medication and put them back under. It's quite distressing. So there are very few people for whom none of these options will work. But for those people, medical aid in dying is something that people want as an option. Medical aid in dying allows a mentally capable, terminally ill adult with a prognosis of 6 months or less to live to request and receive a prescription for medication that they can choose to take to bring about a peaceful death, so long as they're able to self-ingest that medication. That's what we're talking about here. Medical aid in dying is authorized in 11 states, 12 jurisdictions, including Washington, D.C. Delaware just became the 11th state to authorize this option, with the governor signing the bill in just the last month, in May. Nearly a quarter of adults in this country now have access to medical aid in dying. There is a bill pending in the New York State Legislature right now. It's called the Medical Aid in Dying Act, and you'll see that it mirrors the definition of medical aid in dying. It allows the terminally ill, mentally capable adult to request medication from a doctor that person can take at a time of his or her own choosing, or never, so that they can die peacefully, so long as they can self-ingest the medication. Let's break that down a little bit, that's a lot. There were 3 bills pending in New York that would have authorized medical aid in dying in 2015. And the Medical Aid in Dying Act, which took the best of all 3 of those bills, was introduced in 2016. So we've been trying to get this over the finish line for a decade. The bill has been amended several times over the past 9 years to strengthen its safeguards. And it's modeled after Oregon's Death with Dignity Act, which was the first in the country. And normally when, I'm sure many of you have heard this phraseology that states are the laboratories, right? That you can pass a law and then it kind of gets amended, fixed, and tweaked. Oregon's law works. And every other state that has passed a law in this country has modeled its core eligibility criteria and core safeguards on Oregon's Death with Dignity law. None of those core eligibility criteria that we'll talk about in a moment have ever been expanded in any United States jurisdiction. They've all followed the Oregon model because it works. And these are the core eligibility requirements. Someone has to be an adult, 18 years of age or older, with a terminal illness and a prognosis of 6 months or less to live. There is a mental health screening to determine if a patient is capable of making their own healthcare decisions and acting voluntarily. They have to be able to self-ingest the medication at the end of the day. The patient has to be in charge from start to finish, from the initial request to ingesting the medication. None of that can be turned over to a healthcare proxy or a physician or a family member. And it's very important that a patient be able to change their mind at any time during this process. You're not meant to read every single one of these, but this is a long list of safeguards that are attached to the bill, and I'll just pick out a few to talk about. If either doctor has any concern about the patient's mental capacity for such a decision, they have to make a referral to a mental health professional for an assessment, and no prescription for the medication can be written unless and until that mental health professional determines that the person has the capacity to consent to this kind of care. The attending physician has to inform the requesting patient about all of their end-of-life care options, including hospice and pain and symptom management. And this is really important because New York actually ranks last among all states in terms of appropriate hospice usage in this country. That means that people are being referred to hospice too late to get the full benefits, or they're not being referred at all. And one of the things that we know from states that have passed medical aid in dying laws is that once these laws are passed and the conversation between providers and patients open up, hospice care not only is more accessible, people understand what the benefits are, they get the referral. Hospice actually gets better because people are asking more of their providers. They're having open and honest conversations about what they fear most at the end of life and what they need to feel secure. So in states that have medical aid in dying, their rankings in terms of appropriate hospice usages have risen. Another important part of this bill is that no physician, no health provider, no pharmacist, no patient is required to participate. This is a truly voluntary law. And for people who don't agree, once this law passes, nothing changes. But everything changes for the person who needs this kind of care. Public support for this bill is incredibly strong. In poll after poll done by Gallup nationally over the past 20 years, and in New York year after year since the bill was first introduced, support remains anywhere between 68 and 80%. The latest statewide polling shows support at 72%. But if you look at these other boxes, what's really significant around the polling is that it holds steady across political party, age, race, religion, geography. 78% of Democrats support it, 59% of Republicans do. Although you wouldn't know it if you looked at the assembly vote. We'll talk about that in a moment. But there's incredible support for this bill, and lawmakers have been out of step with voters on this issue for quite some time. I think it's important to stop and talk about what the arguments are against this bill. And so I've highlighted a few that I'm going to go into. I'll just say a few words about the ones that are not highlighted, but these are the main arguments that have been made over the past 10 years about medical aid in dying. Of course, there are faith-based and moral objections, to which the answer is simple. If you don't agree with medical aid in dying, you don't have to practice under it, you don't have to request it. But more important than that is that everyone should be able to die in a way that's consistent with their faith and their values and their beliefs, and this law allows for that. It allows people to decide that suffering is the right path, which is how my dad felt when he died of lung cancer in 2014. A certain amount of suffering, thank God it wasn't too long, was appropriate for him because he believed that that was something that was important to his faith, and he was allowed to suffer. People should be allowed to choose not to suffer as well. Another argument is that this is inconsistent with physicians' obligations to do no harm, and people cite the Hippocratic Oath for that. And I think it's surprising to some people to know that there are no medical schools that actually administer the Hippocratic Oath anymore. It is still important, though, to consider the roots of that oath and the fact that do no harm is an important part of that. But many, many doctors now believe that by refraining to offer the kind of care that allows people to reduce their suffering is actively causing harm. And so the edict of do no harm means something slightly different to people now. Another argument is that there's a lack of support among doctors. And I just have to give a little bit of a nod here. We've got a celebrity in the audience who's a member of the Nassau County Medical Society who helped shepherd through a resolution from the New York State, the Medical Society of the State of New York, to support this bill. And so doctors in New York, and I'll show this in a moment, actually support medical aid in dying. And I think lawmakers are finally starting to listen to them. There are also have been concerns from disability rights leaders that advance a number of arguments that are, some are easy to address and some are more philosophical. One is that, this would jeopardize the safety of people living with disabilities. One of the opponents recently even claimed that this puts a bullseye on the back of people living with disabilities. But it's a fundamental misunderstanding about how these laws actually work. No one is prescribing medical aid in dying to you. This is a fully self-directed process where you have to be the one to request and you have to be the one to self-ingest the medication. But some people think that the laws actually say something that they don't, and that people can recommend this to you and prescribe it to you. So that's easy to sort of dismiss. It's a misreading of the law and what's happened in other states. But then there's a concern about what's called the slippery slope. And if any of you read the New York Times Magazine, you may have seen a cover story on Canada's physician-assisted dying program, where the specter of the slippery slope was raised because in that state, or in that country, they adopted a physician-assisted dying law, which allows for euthanasia, by the way, which our law does not. Euthanasia is someone else taking action to end a life. Our law is completely patient-directed. But in Canada, they did expand the eligibility criteria. So you no longer have to be terminally ill. You can have a mental health disorder. And so people say that once you pass a law like a medical aid dying law in the United States, it would be easily expanded. Well, George Will, the conservative columnist, wrote a piece in the Washington Post in 2015 where he said, the slippery slope could be applied to anything. Public education could become indoctrination, law enforcement could become authoritarianism, and we are the guard against this. That we have, as a society, the ability to make intelligent distinctions. And if there were a slippery slope, it would have happened in this country already. These laws have been in effect in Oregon for over a quarter of a century, and none of the core eligibility criteria have ever been expanded to include anyone that isn't terminally ill. But then there's a last question that disability rights advocates raise, and that is that it's about devaluing the lives of people who can't engage in certain functions. And so you often hear people saying that they wouldn't want to live any longer if they couldn't engage in the activities that they love. And in some way that influences people living with disabilities who may not be able to engage in those activities either, caring for themselves, etc. And it's a deep concern that people have. The question is, should it outweigh the right of other people to be able to say enough is enough when they're actively dying? Another concern, which seems a strange concern to raise as an opponent, is that New York does rank last in terms of appropriate hospice use, and we should instead focus on improving access to hospice and palliative care instead of passing a medical aid and dying law. But this ignores the evidence that more than 86% of people who access medical aid and dying in states that have it are already receiving hospice and palliative care. That some of the leading advocates here in New York who have wanted medical aid and dying were receiving excellent hospice and palliative care at some of the premier institutions offering this care in the state. It is, as one hospice provider said, arrogant to assume that we can alleviate all suffering at the end of life. And it also ignores the fact that many people want the option of medical aid and dying because they want to have some agency over an illness that has robbed them of all other agency that they have. There's a worry about the Canadian physician-assisted dying law that's related to the slippery slope issue. And there are new arguments that have come up just in the past few years about racial justice and healthcare disparities. Certainly, I mentioned the Senator Joni Ernst comment earlier, but there's a real cold-hearted effort to cut Medicaid benefits and to make it very hard for people at the lowest socioeconomic strata to access quality health care. And I think we can't ignore that. But that happens in states that have medical aid and dying and states that don't. And the outcome is no different. People are dying because they can't access good health care. And in states with medical aid and dying, they might be able to suffer less. But in states without medical aid and dying, they're dying. And that's why I find it so interesting and hard to kind of reconcile her comments about death and dying, because it's true. It is true. It's just that some of us approach that with more callousness than others. So those are the arguments that opponents make. I'm going to just show you that this is a poll done by Medscape that shows that doctors in New York support medical aid and dying when they were first asked the question, 56% of them supported it and 26% opposed. But then when they were told what New York's bill would do and not do, that support grew to 67% and the opposition decreased to 19%. There is significant support for medical aid in dying among people living with disabilities. A nationwide poll shows that 79% of people living with disabilities believe medical aid in dying should be legal. And that was a poll done in 2023. And more organizations that support people living with disabilities are coming on in support of this. So I think that some of the arguments by leaders in this community can't be read to show that all people living with disabilities or the groups that represent them oppose this. The ARC of New York is one of the oldest and largest disability rights organizations in the state, and they have a policy in favor of medical aid in dying. It's really interesting to me, when I took this job, I had worked on disability rights when I worked for the New York Civil Liberties Union, and so it was a concern that I had. So I did my research, and I found that the Disability Rights Oregon, which is the watchdog agency in Oregon for people living with disabilities, affirmed every single year that they had never received any complaints from people about misuse of this law. And the last letter that they gave us was like 20 years of these letters, every year the same thing. He said the only complaints that they have received were from people who wanted to access medical aid in dying who couldn't, because of the strong safeguards. And that to me says a lot. If there had been problems with this law in other states, we surely would have heard it, and certainly from the Disability Rights Organization in Oregon. I also just want to show that the Canadian law is very different from the model of medical aid in dying in this country. The fundamental criteria here I've gone over a number of times. You have to be terminally ill, mentally capable, able to self-ingest. And in Canada, they don't require terminal illness. They don't require a 6-month prognosis, and they don't require the person to self-administer medication. It is administered by the physician. Euthanasia is prohibited in every state in the United States. It would be prohibited by the New York Medical Aid in Dying Act, and euthanasia is allowable in Canada. I think another thing to note is that more than 60 statewide and regional organizations have signed on in support of this bill. Notably, as we know, the League of Women Voters, the Medical Society of the State of New York, the New York State Bar Association, the New York State Nurses Association, the New York State Psychiatric Association. So there's tremendous support in the civil society groups for this bill. So who uses medical aid in dying? Very few people. In New Jersey, since the law took effect in 2019, 287 people used the laws within 4.5 years of reporting. The new report is supposed to come out in a few weeks. I imagine it might be close to 400 at this point. What we see is that there's a very slow adoption rate, and then the rates go up a little bit as the law becomes more familiar to providers and to society, and then it plateaus. And in Oregon, we're seeing that the rates are dropping a little bit. And that might be because hospice and palliative care is getting better, the access is getting better, but at some point these laws plateau, and just about less than 1% of those who die in authorized states end up using these laws. Terminal cancer accounts for the vast majority of qualifying diagnoses, with neurodegenerative diseases like ALS or Huntington's disease following as the second leading diagnosis of people that use medical aid in dying. Earlier I said that most Americans say that they would like to die at home, and these laws allow for that. And so about 90% of people who used medical aid in dying were actually able to die at home. More than 85% of them were receiving hospice care at the time that they died. More than a third of people who receive a prescription in states that authorize this law never end up using the prescription, but their families report that they received a tremendous sense of peace of mind, knowing that this would be an option if their suffering became too great to bear. So, let's talk about the legislative process and where things stand. As I mentioned, the Medical Aid in Dying bill was first introduced in 2016, and the bill passed the Health Committee that year thanks to Republican Assemblymember Janet Dupree, who shared the story of her mother's death after using VSED, voluntarily stopping eating and drinking, and how horrible that was for her family. And so the bill easily passed that committee, and then it stopped. And it's died every single session until this year. And the Assembly passed the Medical Aid Dying Act on April 29th. It passed on a vote of 81 to 67. No Republican votes, which we'll talk about if you'd like. And there were 65 bill sponsors, but there were an additional number of lawmakers that voted yes on the floor when the bill came forward for a vote. In the Senate, we currently have 25 bill sponsors, but it takes 32 yes votes to pass a bill in the state Senate. The diversity of the bill sponsors is incredible, both in terms of race and tenure and geography. They're from all over the place, and many of them come to this issue because of a personal experience in their own lives. June 12th is the last day of the 2025 legislative session, so what is that? Soon. The bill has to pass both chambers in the same session, and New York has a 2-year legislative cycle. This is year 1. So all of the progress that has been made this year could carry over to next year, but it's very difficult for lawmakers to take up what they consider to be a controversial issue in an election year. So this year becomes very important. It has to be voted on by the full Senate, and then the bill, if it passes, is sent to Governor Hochul, who can sign it or veto it. The Senate often holds bills until the governor requests them, effectively allowing the governor to control the timing. So even if the Senate passed the bill by June 12th, it could be several months before the bill is sent to Governor Hochul. There are regulations that need to be created to effectuate this bill, and so I would imagine that the governor is going to hold the bill if she gets it from the Senate, or if it passes the Senate, she'll probably ask that it be held for a while those regulations are created. If the Senate does pass the bill in 2025 by June 12th, then the governor has until December 31st to sign it. So it's about a 6-month period that she has. But if the bill isn't passed by both chambers by June 2026, it'll die, and then it'll have to be reintroduced in 2027, which will make it a 12-year legislative campaign. Not unheard of for big legislative change. If you think about marriage equality, medical marijuana, those major things took a long time. I think when I was introduced, you heard that I worked on the campaign to modernize New York's abortion law. That was a 13-year campaign, and for the first 11 years of that campaign, nobody believed us that Roe versus Wade was in jeopardy. We knew that we had to have something in state law, but sometimes it takes a long time to convince lawmakers to do the right thing. So, what are the benefits of having the option of medical aid in dying? Medical aid in dying honors patients' autonomy and protects the doctors who serve them. There has not been a single substantiated incidence of abuse or coercion since Oregon passed the nation's first medical aid in dying law in 1994. That's over a quarter of a century, as I mentioned before. No cases of abuse, coercion, or misuse. Very few people will choose this option, but large numbers of people will derive peace of mind simply knowing that it's available. Adopting New York's medical aid in dying law will cost the state nothing, but the cost of inaction is really high. Terminally ill people may not try that one last miracle treatment out of fear that the treatment will be too painful. Far too many choose violent means to end their suffering rather than this compassionate option. People are being deprived of the peace of mind that comes with knowing that they can end their suffering if it becomes too great. And people will die suffering if this law is not passed, while families and doctors remain powerless with no legal ways to respond to their pleas for help. We also fail to gain these other benefits from medical aid in dying implementation. Better use of hospice care, as I mentioned, improved conversations between doctors and their patients where people don't have to fear expressing what they're worried about at the end of their lives. And this drives physicians to get better training in how to respond to their patients' requests. So, getting to the finish line, what can you do? As I mentioned, there's widespread public support for medical aid in dying. I have traveled every inch of the state from the furthest tip of Long Island all the way to Malone in the North Country, from Buffalo to Brooklyn, and people are writing to their senators, they're calling their senators. If you live in the Port Jefferson area, I put in the address of the library. Senator Jack Martins represents this area. He is a Republican, but he is listening. And there are postcards in the back. I don't know how quickly you can get one of those to his office, but if you can call him or drop him a postcard, he really needs to hear from you. And if Jack Martins is not your senator, you can talk to me afterwards. I can tell you how to find out who is. But they need to hear your voices. They need to know how important this is for you. We changed our messaging midway through this campaign, where we talked about suffering for the first 6 years of the campaign, how much people suffered, and nobody wanted to talk to us at all. And so we changed, and we started talking about how this isn't really about death at all. It's about life. It's about what the ends of our lives look like and what they can be, and how they can be just as beautiful as the beginning. I think, I don't have kids, but I think about how joyous it is whenever you find out that someone's having a baby, right? It doesn't matter what the circumstances were. Is it wise? Is it smart? Is it the right time? It's a joyous occasion. What happens at the end of life? We close the door. Our circles get really narrow. It becomes too sad. It doesn't have to be that way. We've seen people take charge of their end-of-life experience in states that have medical aid dying, and it's beautiful. How many times are you at a memorial service and you hear people talk so movingly about the person who's just died, and you think, I wish they were here to hear that. Well, this is possible. When people can orchestrate what the end of their lives look like, it can be really beautiful. So what can you do now? Community groups can join the civic organizations that have supported the bill. You can write letters to the editor. You can call your state senator and urge passage of this bill before they leave on June 12th. You can record a selfie video and send it to us. We'll put it on social media. You can host community discussions like this, so thank you so much for doing this. And finally, you can write a letter to Governor Kathy Hochul and urge her to sign the bill if the Senate passes it. And I left postcards in the back so that you can take one and write a postcard to Governor Kathy Hochul. And that is what I have to share with you. So you can certainly scan the QR code if you want to learn more about medical aid in dying and some of the things that I mentioned, or you can email me or call me. But I would love to hear some of your questions and thoughts. Yeah.
So once you get to New Jersey, you don't have to be a resident. And the question is being a resident. I understand that you don't have to be a resident of New Jersey to die in New Jersey. Is that correct?
Unfortunately, it is not. New Jersey's medical aid in dying law has a residency requirement. It's being challenged in the courts right now, and I think ultimately it will be overturned. But in Vermont, you don't have to be a resident.
Okay, got it. Thank you.
I have a question about coercion. What safeguard is there in the law that would prevent someone from trying to influence a dying person to
There are actually felony penalties in the law for coercing someone to use medical aid dying. First of all, the doctor has to interview the patient, and the patient has to present to both the treating physician and the consulting physician, and then they have to make an oral request to both of those physicians and a written request, and that written request needs to be witnessed by two people who have no interest in the person's estate. So, if you think about it, coercion from a family member sounds like a very scary thing. But under this law, why someone would go through that and then have the terminally ill person convince two doctors and two witnesses that they were doing it of their own free will. What's really important for people to understand is how people die now. If there were a family member who wanted to make someone die sooner, the means exist without having to go through the formal process of medical aid dying. Someone could not take the person to a healthcare visit. They could over-medicate, they could under-medicate, and there are no safeguards. When someone is sent home on hospice care, they're given a packet of medication that they administer to the patient without any oversight at all. That's happening today. Medical aid dying is actually the only option that requires the patient to do everything from start to finish. And that's what's important to understand about this bill, aside from the felony penalties attendant to coercing someone.
Can you explain to all of us the role of a death doula?
Death doulas are people that accompany the person throughout their end-of-life journey and help them realize all the things that they want for their end-of-life experience. Kind of like a birth doula, It's being present with the person. Different doulas offer different services. There are some doulas that pair their services with helping the person catalog all of the art or the writing that they've done. How do they tie up all of the loose ends? How do they create a dying experience that is consistent with the way that they lived? How do they help the person manage tying up all the loose ends?
The hospital, the caregivers can set up a hospice and palliative care. How does somebody access a death doula?
There isn't a central way to do it. You just have to Google death doulas and find them in your area. We can certainly refer people to death doulas through our end-of-life consultation program.
This will involve clinicians, physicians, and this is something new for those who will be in New York State to do this. Could you discuss how physicians will learn about the medications and the process, et cetera? Is there already a network to educate clinicians to be able to help their patients avail themselves of this important service?
There is. There are a number of resources. There is a national organization that provides resources to people who practice, but we have really strong partners in the New York State Academy of Family Physicians, and I hope in the Medical Society that when this law passes, which ultimately it will, it's just a matter of how much more suffering lawmakers will allow. But once this law passes, I think the New York State Academy of Family Physicians has already begun putting together trainings for physicians. And we have a peer-to-peer mentor program at Compassionate Choices where it used to be called Doc to Doc. And so doctors can call our medical hotline and be mentored by a doctor in a state that has already practiced medical aid dying. But it is, how to prescribe the medication, how to do the screenings, all of that has been written about in numerous medical journals. The practice of medicine evolves, as you know, and so the literature has been keeping up with that. There's a lot of resources out there now, much more than when the law passed in New Jersey in 2019, actually.
How do insurance companies feel about this bill?
They have not weighed in publicly. there are a number of private insurance companies that cover the cost of medical aid in dying, the visits, the medication, and then there are other insurance companies that don't. So, yeah. There are no significant cost savings to medical aid in dying. That's one thing that people are concerned about, is there a financial incentive here? And we've all heard that healthcare at the end of life is the most expensive, right? Only up until a point. When you are at the 6-month mark, when there's no more curative treatment, the cost of healthcare drops precipitously. And hospice is covered by federal benefits. And so the very last part of end-of-life care is not that expensive at all. So there are no significant cost savings at all with medical aid in dying. That's not a motivating factor for people.
I think you should also mention that insurance listed their terminal illness as on the death certificate, not.
Oh yeah, that's another part of the insurance question is do people's families get life insurance benefits? And the answer is yes. No one who's ever used medical aid in dying in a state that has this as an option has ever been denied life insurance.
In the proposed New York bill, what is the time frame once someone is approved for medical aid in dying and the medication is to be administered?
So when someone is given a 6-month prognosis, when they've been given a diagnosis of a terminal illness and then a 6-month prognosis, they make the oral request to the treating physician, and then they have to make another request to the consulting physician, and then they have to make a written request. And so that takes, just in practice, several weeks. There is no time frame laid out in the law, but what happens in practice is that it's often difficult to find providers that are willing to engage in this. And so finding the consulting provider could take weeks. And this is, people have been thinking about this for a while. So there is no time frame between prescribed by the law for when people get the medication. But the process in general takes around 6 weeks at best to complete.
A couple of comments. So first of all, a correction. I think you said that in Canada, the medical aid in dying allows mentally ill patients to be given medical aid in dying. That's not correct. That was in the bill there. However, it became so controversial that and so strongly objected to by Canadian psychiatrists that it was postponed and it's now scheduled to take place in 2027. And that has become an issue in the U.S. Amongst psychiatrists now because of the difficult question of how do you determine psychiatric utility as opposed to medical utility.
Some mental health disorders are not, you might be right with that actually.
No, they're not. Well,
There's 2 tracks though. One is you need to be terminally ill, and then the track 2 is what they're calling it, is you don't have to be terminally ill.
No, you have to have irremediable suffering.
Irremediable
And
suffering.
that's what the patient in the New York Times on
Right.
Sunday has.
Right.
So that has changed things a lot there. In Canada also, by the way, in response to your own question, there is now a very well-developed network of MAID providers who are strongly organized in terms of protocols and how to go about it, etc., as well as a very strong training program that they have.
Yeah, that's true. That's right.
One of the dilemmas is the words we use. And in an article in Newsday, it comments calling this medical assisted suicide. And I tried to rebut that in the discussion I had with a reporter. And I'd like you to comment because I think it's critically important that we clarify that this is not suicide. And if you would embellish on those thoughts.
Yeah, there's so many different ways to address this concern, and opponents basically just take out the Merriam-Webster dictionary and they say the taking of one's own life is suicide. And so it's hard to argue. But when you talk to people who want medical aid in dying, or you talk to people whose family members talk about how their loved one used medical aid in dying, these people are not suicidal. They want nothing more than to live. It is the terminal illness that's taking their lives. So this idea that it's suicide is hurtful to terminally ill people, it's hurtful to their families, and it really ignores the distinctions between the ways that someone might end their own life. I was recently told that there are 4 German words for taking one's own life that actually talk about the different kind. I mean, for example, a soldier throwing themselves on a grenade. That is, the person is definitely taking their own life, but why? Is that suicide? Do we talk about it that way? And so the bill is very careful to lay out, not only for insurance purposes that this is not suicide, but as an acknowledgement that the person is actually dying of a terminal illness and wants only to shorten a period of suffering. So I think that's why it's important. And suicide it's a lightning word used by opponents to kind of jar people into thinking that this is not something that we want. But when I hear stories of people who have taken matters into their own hands because of their own suffering, whether they've attempted to take their own lives by, using medication that's been stockpiled or a more violent means, it becomes very clear to me that this bill is about suicide prevention. No EMS professional should have to deal with someone who's terminally ill and takes a gun. It shouldn't happen that way. And that's one thing that we can do to make sure that that never happens again.
If you want to go to Vermont, are there more bureaucratic steps to do so? I mean, if you're not a resident.
I mean, you would have to find a physician, a consulting physician, and go through the same process as in New York. And most people just don't want to leave their homes to do that. And when they're terminally ill and it's 6 months, with 6 months less to live, it's very difficult to pick up your whole life and move and find a new care team. But people have done it. It's not common, but it's possible.
Another thing is with the doctors, aren't they afraid of getting sued? I mean,
no doctor has ever been sued for complying.
No, in general. You said that the doctors are not coming forward with this. They don't want to get sued.
No, I don't think it's because they don't want to get sued, because these laws provide immunity for doctors who comply with all aspects of the law. And there's never been a case against a doctor because doctors are careful to make sure that they comply with all aspects of the law.
Yeah.
I think it's more of a maybe an uncomfortability at first. I mean, in Oregon, it's much more accepted as an end-of-life option, and so there are more doctors that participate than in New Jersey, where it's relatively new.
I have a friend who committed. She administered the whatever the formula was, and I, as a friend, would have felt a lot better about her having gone through it with the physician assistant, with the medical aid in dying process, rather than doing it on her own and stockpiling. And I don't know what her end of life may have been like for her. She died alone. And as a friend of someone who felt it necessary to end her life, it certainly would have been nicer to know that she was given the proper and appropriate care in her dying.
There's incredible stigma around suicide, and people who feel that they have no other option do often die alone. They try to insulate their family members and their friends. And so, yeah, I mean, this allows people to have an open and honest conversation and invite the people that are most important to them into that last act in their lives.
Also, do you have a list of the senators, the New York State senators who are opposing this?
Any senator that is not listed as a bill sponsor is someone that should be contacted. Actually, all senators should be contacted because even the ones that are supporting the bill need to know how important it is for them to do this. They've got a lot on their agenda between now and the end of the session.
Okay, because even if it's a senator who's not in my district, but it may be in my brother's in Cooperstown, I can let him know.
I think all of us should be calling our senators now.
Yeah, thank you.
I feel badly that people who have cognitive decline, who have been diagnosed with Alzheimer's, early onset, who have no choice, but they know that they're not gonna be able to be competent. It's not a terminal illness, and they wanna end their lives because they don't want to be, non-compos mentis or inflict that on their family. Was there any kind of consideration to that? Because it's not terminal, really, and they can't make a decision later on.
Right.
So medical aided dying is not going to solve all of our end-of-life care problems. We have a lot of work left to do. And this issue of Alzheimer's and dementia is one of the most common questions we get. That's why Compassion and Choice has spent a great deal of time, about a decade ago, developing a dementia values tool. And you can access this online on our website. And basically what it does is it allows you to go through the various stages of dementia and say, this is the kind of care I want and the kind of care I don't want. And so what does that translate to in real life? That means that if you have dementia and you have put in place what some people call a dementia rider on your living will that says you don't want any curative treatment, none. That means if you go to the hospital with a broken hip and you develop an infection, they're not going to give you antibiotics. And if you don't get antibiotics, you will die of an infection. That's the kind of advance directive that you can put in your living will right now that ensures that if you have dementia and you need medical care, it won't be provided if you've already said you don't want it. It's a really effective way for people to say enough is enough.
Dying infection is very horrible.
It isn't, actually.
What?
No, sepsis, you die in 3 days.
It isn't.
It's over.
It isn't. So, I mean, it's something that you can all do today to plan for that eventuality. And there's a number of other nuances, but that's just one example of a way that you can take control of your healthcare at that point through an advance directive.
A few weeks ago, the league sent out an email saying, call these 5 senators and their Stewart cousins. Are we still encouraged to call the majority leader? I mean, and I certainly think we need to call the governor, but we can call the governor after it passes.
I definitely think that polite calls into the Senate Majority Leader's office to say, this has got to be on your end of session priority list could be very helpful.
Well, I like the message, I was polite. It's that I really believe in this bill, having sat with terminal family members who suffered needlessly. And while they are now gone, there are still many people going through this today, and I would like this bill for myself.
I think that's an important message for all senators to get right now.
Okay, second question is the verb keeps being ingest. And so ingest could be chew or swallow, or are there variations? Because I assume that some people one of the things that happens when you get very sick is your ability to ingest changes.
So the bill does not set forth the kind of medication that's to be used, and that's smart for a whole bunch of reasons. One, you don't need lawmakers telling doctors how to practice medicine, first of all. Second, there are changes in the pharmaceutical industry all the time. There are advances in medicine, and you wouldn't want to have a law that stuck a particular protocol in time. So that's important to understand. Another is that this is not a pill. A lot of people think of this as a death pill. So this one pill is going to be out there and it's going to be hard for people to keep control of. It's not. It's actually a compounded medication that's used in combination with other medications that help absorb the drug, that help stave off a gag reflex because the medication is difficult to ingest. It is mostly mixed with 6 to 8 ounces of liquid from a compounding pharmacy, that mixed with the liquid and ingested through drinking. It can be ingested through a straw. It can be ingested through a feeding tube, so long as the person has the ability to take that last decisional act by pressing a button. There's a whole bunch of ways that this medication can be ingested. The key is that the person has to take that last decisional act.
So were I to have something like Lou Gehrig's disease, and I control things with, I don't know, the one patient I knew controlled things with eyebrow pitches, could something where I guess if you're adding it to a feeding tube, I could also add it to my IV tube or my port of some sort?
Well, it's not an injectable, so it's not
But it has to go through.
the gastrointestinal system.
Okay.
That's right.
Can a hospice worker enable somebody what might be needed to ingest that dose?
A healthcare provider, a hospice worker, a family member can help set things up, but the person has to take the last decisional act.
But the hospice worker can do some of the setup, can be involved in this, but the patient himself has to push the final.
That's right, they have to be the ones to,
But there are no
Bring the
restrictions
medication
on what
to
a
the
hospice worker can do.
unless the hospice doesn't want to participate, in which case hospices can actually tell their workers.
There's no law prohibiting that.
There's no law prohibiting that, that's right.
Is the 6-month prognosis arbitrary?
Yes and no. 6 months is the common eligibility criteria for getting into hospice in most states in this country, and that was not arbitrary if you consider financial considerations not arbitrary. So 6 months is a bright line that the federal government has used to cover the cost of hospice. In New York, we're a little bit more enlightened, and we allow people to access hospice care when they have a 1-year prognosis. And I think lawmakers, in order to pass laws allowing for medical aid in dying, needed a bright line. And it was just as easy to say most hospices will admit you at 6 months. So 6 months is the line for medical aid in dying. So not entirely arbitrary.
Well, if you diagnose with, I don't know, cancer, it doesn't matter, and like you really don't want to do anything about it, or you just want out. Isn't the medical establishment, don't they have to make sure that you're not gonna suffer and then just gonna keep you hot? You see what I'm saying? Yeah, it's cancer, okay, I don't care, I want out. Aren't they obligated to make sure that you're not writhing in pain from it? And then, you know what I'm saying?
No, they're not.
What?
All you do is you don't go to the doctor.
Yeah, but you still.
Oh, so you're- Is your question, are they required to give you pain medication?
Right.
Well, my husband had cancer, and it took 6 weeks to figure out how to get him out of pain as he cycled through various combinations of serious painkillers, including fentanyl, okay?
I
Which
mean,
did not kill him, and
Okay.
it only managed some of the pain when it was in combination with various opioids
Okay.
and several others. But it took forever, and it did not end the pain.
Okay.
I think your question is what are the obligations of a doctor when someone is suffering at the end of
Right.
life?
You know what I'm saying? I don't want treatment. I don't want chemotherapy. I don't want anything. I want out.
Well, the courts have all affirmed that people have the right to say, I don't want to receive any more treatment.
Yeah.
But I thought your question was about what the doctor's obligation
Yes,
is.
that too.
Certainly doctors have an obligation
Right.
to help people not suffer.
Exactly.
And the existing tools that they have at their disposal sometimes don't.
Okay, so that's
Guarantee
what you're
that.
saying.
That's what I'm saying. Pain medication sounds wonderful until you're in serious pain. And then they may or may not work.
I see, okay.
So with regard to the term physician assisted suicide, psychiatrists know that patients who want to hasten their death are not comparable or equivalent to clinically suicidal patients. The differences, and speaking as a psychiatric clinician, are so clear that they don't even have to be enumerated. Unfortunately, the American Psychiatric Association has not made the distinction, and we have been trying to get them to do so, and that may yet happen, but certainly, there is considerable understanding in the profession that the fewer understand.
Yeah, you're right. I mean, more than half a dozen national medical organizations have rejected the term suicide, but not all have. And I think that at some point we will reach a point where most of the medical establishment recognizes those fundamental differences, but we're not there yet. So thank you for your work.
What was the question?
It was the fact that the American Psychiatric Association has not yet made the distinction between suicide and people who choose medical aid
But
dying.
you don't know anything anyway.
Well, individual psychiatrists, as the questioner said, do understand that there are profound differences between people who are suicidal and people who want the suffering to end. Thank you. Thank you very much.